rotational plane. So looking at all three, we had a little bit of discussion that you don't necessarily have to have it in all three. I think Andrew was saying or something like that.
Well, sometimes with
Yeah, exactly.
you've got an
Yeah, exactly. Yeah.
but you won't
So,
have that rotational
so
one.
this doesn't fit all of them, but you know, it might fit some of them as a neat little definition, I guess, of it. So, what might the patient report? So, they might come in saying that we're not able to stand up straight. Sometimes the parents that have more concerns and see it more than the actual. So some of the things that they might report, age is more over to one side. When they're looking from behind, their shoulders or pelvis don't look level to them. They may be standing with one leg bent to kind of correct that trunk alignment. They may have increased kyphosis. That's obviously primarily in the thoracic spine, but that kind of curve forward there. S-shaped spine, which was in a bit of discussions there as well. They may have secondary curves above primary curves. They won't necessarily be saying this, but with scoliosis, you can either have balanced or unbalanced scoliosis. Okay, so balance would be where you've got a secondary curve that balances out the first one, and unbalanced would mean that it doesn't correct that, so then you are over to more one side. And you've also got increased lung lordosis, so obviously that more extension in the lower back as well. So, types of scoliosis. So, within this presentation, I'm not kind of looking just at children, I'm looking at kind of adults as well. Primarily, you'll kind of see this more so in children, or there'll be more kind of intervention, I guess, more so with children than adults, but as you'll see in a minute, there is one type with adult scoliosis as well. So first type is you've got functional scoliosis. This is due to extra spinal components such as muscle shortening, so muscle spasms, things like that. So you can get it as a result of this, basically. Then you've got structural scoliosis, which has got some subtypes underneath that. So you've got idiopathic scoliosis. This is where there's no reason for the scoliosis in the child or the teenager. You've got neuromuscular scoliosis. So this is when it's within people with basically neurological problems or problems in the neurological system. So for example, people with cerebral palsy, people with stroke, people with muscular dystrophy. So some of the more extreme examples that I've heard about before are more with kind of learning disability patients. When they have those things, and also disabilities can't correct that as much. You've also got congenital scoliosis. This is where you're born with it due to abnormal shape or development of bones. And then finally, we've got the adult degenerative scoliosis. So this is scoliosis within adults. It could have developed as a child, but it only starts to cause problems when they're older due to degenerative changes. And as a result of degenerative changes, then the worsening of the curvature. So another name for this is de novo scoliosis, just in case you kind of come across that in referrals or something like that. So how do we look at kind of guidelines on assessment treatment now? So looking into it, so kind of main body for the guidelines is SOSORT, so that stands for the International Scientific Society of Scoliosis, Orthopedic and Rehabilitation Treatment. So for short, SOSORT. So they set out guidelines. These ones here are back from 2012. They have put up some more recent guidelines as well that you can kind of look into. I think they was released about 2018. So what's kind of the assessment guidelines? So it's recommended that Adams test for scoliosis screening purposes are used using a scoliometer. So you can see that at the bottom there, that picture there. So it's basically like almost like a kind of a protractor type thing, so you can look at the angle of the rotation. It's also recommended that assessment includes pathological, cosmetic, psychological, functional, and family aspects. So we kind of do this with quite a lot of our patients anyway, but more particularly so with people with scoliosis. So I'll give you kind of the extremes of more with the psychological, one with myself and one with a patient. So just to kind of give you an idea of kind of how it can impact you, let's take my example factually. So I was doing physiotherapy, I was somewhere else. I had a problem with eczema, so I had a lot of redness around my face, redness in my face and these sort of things. And a patient came in to me and said, you look as bad as I feel. So that was 2 years ago, and I can still vividly remember that. So that shows you how, if someone says something, it can impact you for a long, long time. And that's just an example from me. Another lady I had the other day with scoliosis. Don't think she said anything to a friend, but a friend said to her, oh, I didn't realise your back was that bad. Ooh. So much to the point that she was then crying in the assessment when she said this. So it kind of shows you how you need to address these issues as well as the actual physiotherapy things. It shows you these other elements you need to look at as well. So that just gives you a couple of examples there. Recommended that a sagittal alignment of the spine is evaluated, as well as the frontal and the rotational alignment. Okay. So, and it's recommended not to perform X-ray if Adams' test is negative. It's recommended that the first and last radiographic evaluation include a standing lateral view. So obviously that's where they're standing, so they're weight bearing on it, so you can see any weight bearing changes. And it's kind of looking from the side there. Tends to be that X-rays primarily done by consultants because they can get the kind of the standing X-rays or have more access to these ones. It's recommended that all idiopathic scoliosis patients, even if not treated, are regularly followed up until skeletally mature in children. So, using another example for this. We come to the end about a little lecture was done by one of the spinal consultants, but one person brought up a question that they said, oh, someone with scoliosis, I tried to send them for an X-ray to degree of the scoliosis, and the radiographer said they weren't going to do it. And he essentially said, send them to me, I'll make the decision, we're the consultants, we need to follow them up. I don't really care what they say almost. We need.
On X-rays, you've got a lot of radiation, and it has to be repeated when they see the consultant. And it's only the consultants that can do the long spinal X-rays.
Yeah, exactly. So that's what he's basically saying, and is completely correct there. That basically, if you've got someone that you suspect does have this, it's always best to, and I know Anja has at least one occasion, get them referred on to the consultant, basically, so they can have a look, they can get the necessary imaging that they need.
Is that for children and adults? Is it, or just?
I guess more so children because they can develop more. So we kind of come to later. So if they've got like a small curve, then it might not develop into anything kind of awful. But if they've got like a larger curve, as they get older, that curve may increase more and more and more, and then you've got more problems. So more so with children, yeah. So I think just so we've got a bit of context of what kind of Adams test is, we may be coming on to it in a bit. Let's have a look. No, okay. We'll come on to doing a bit of practical on trying Adams tests on each other a bit later in the presentation. So the final thing is, so it's recommended that the curve magnitude is measured using the Cobb method. I don't know if anyone's ever come across this before. I think some of us have, some nods. Yeah. Okay. So this picture shows it quite nicely. So you're basically taking from the bottom of the spine where the curve starts, or where the primary curve starts, to the end of the curve, on the top, bring those 2 points together, and that angle gives us our Cobb angle there. So that's used a lot in kind of recording and measuring spinal deformity, more so scoliosis, really. So if I, and at the end I'll just show you a couple of a video using more a computer-based system, which kind of, okay. So treatment guidelines. So what's recommended? And these again are in the SOSORT guidelines. So physiotherapy specific exercises are recommended as a first line to prevent limb progression and a need for bracing in children. So that's good, good for us, pointing towards us doing an effective job there. It's recommended these exercises are based on autocorrection in 3D, looking at activities of daily living, stabilising the best posture and patient education. So that kind of comes back to a little bit of our kind of definitions of they may not be in all three planes, but looking in all three planes, and if they are in all three planes, then treating in all three planes rather than just one plane. It's recommended that exercises are personalised and carried out regularly. So personalised as a definite, carried out regularly. As we know with kind of paediatric patients, some are quite compliant, some are not so compliant. So it's all about making it so they will be as compliant as possible and making it so, as we know, something that they'll enjoy doing, something fun, so they're more likely to do it more regularly. And we come on to a bit of a trial later that shows the regularity that you need to kind of get these effective changes, which is a lot basically. We're talking 2-3 sessions a week, hour to an hour and a half. So, and that's just in one trial. I mean, obviously it may get results in a shorter time, but that should affect it and shows how often you need to do it. It's recommended that when needed, that exercise to improve breathing function are used, both while embracing and when not. So in children, it's also recommended to train with specific exercises to promote expansion and ventilation in specific areas. Has anyone seen any of this done before? I think anyone done any of these? Okay. So one of the main ones we're going to come on to later is the Schroth exercise method. So this was basically created in Germany. By a lady in Germany. That is based on exercises that correct in the best posture, but also getting breathing and ventilation in the correct areas. So this is kind of following this a little bit. But obviously we can do ventilation without these particular exercises. You can just work on that ventilation, making sure breathing's in the right areas. Because obviously, as you can imagine, if you've got a curve, you're passing down certain areas that need to be expanded back out again. And stabilisation exercises are recommended. They didn't really state what particular ones, but the stabilisation exercises, and we all have our own ones that we do, and it's just about picking the right one for you that you are confident and you like doing, and you find good results from, and something that will work for your patient. So, not really scripted there. So, what is not recommended? So it's not necessarily with this what's not recommended, but what's not recommended as a standalone on its own as a treatment, if that makes sense, just as an adjunct onto this. So it's not recommended that sport is prescribed as physiotherapy intervention. So what I mean by that is just as the only treatment with nothing else. So you can still do it, and obviously you would still want to do it, for general sports activities for global benefits, as long as they're okay to do that, and if they're seeing the consultant, if they're in children, are happy for them to do that. Yeah, that's what it is. And again, manual therapy is recommended with short-term mobilization and releasing soft tissue only if done with stabilized exercises. So you don't want to do it just on its own with nothing else. You want to do it with a stabilization exercise program of whatever choice you want to make. So, how can scoliosis be performed? What simple things can we do to look at this without the standing x-rays I've got here? So the picture on the far left there shows Adam's test. Okay, so we'll have a go at this in a second. So it's basically looking for what we call a rib hump. So on this case, I think it's on this side here. You're basically looking for where's the body higher on one side than the other. So looking at, that's what they call this rib hump, basically. And that gives you some indication of the spine and certainly the rotational element of it. So maybe if, just to kind of keep you active, because you've been sitting there for a little bit of time, why don't we all kind of have a stand up? Perhaps just having a look at that, see if you can see anything, you can see if you feel the spine looks straight on the partner or whatever. Yeah.
I'm going to be videoing someone doing this, just to warn you. Right. Go on then. Cheers, Luce.
Yeah, it's a little bit on the right.
You do?
A little bit.
Right, hold on, Luce.
That's significant.
Yeah.
Tom! I've just shamed you to Laura now.
Do it again. Okay.
Do you want me to do you want me to roll my top on?
Yeah. Yeah, we do.
I feel like a one.
Get all the way.
Take it off, please. I've got a muscle bulk difference.
It's definitely there.
Yeah, I'm happy to.
Small one.
Do you want me to do anything else other than stand there?
Oh, you're doing a good job there, actually. Can we have a look at your spinal alignment?
Yeah? Cool. What do you mean by that?
Just if you just stand up. Wait, just so we can have a look.
Muscular.
Yeah, you look straight.
You're right-handed, are you?
Yeah, because you're right-handed.
Do you do sports, one-handed sports?
No? Really? I always tackle more on my right than my left.
You can just have bigger, like, erector spinae bulge as well, can you?
Yeah, this has always been.
bigger legs.
Yeah. But I also have a really bad scap on this side, so I don't know if that also So I got a bit of scoliosis. Good to know.
Right, funny, yeah.
Maybe a postural.
Okay.
Yeah.
Yeah, probably.
You need to have a standing X-ray.
And actually, the first time we did it, it showed it more than the other two.
Don't know.
Well, you were a good person to video for our training.
Great, perfect. Anyone else have one?
Okay, go on then, Tom. Oh, he's too bendy. You can't see his back.
Actually, yours is a little bit on that side. I think everyone has a slight muscle.
Just go.
Spectrum of normal.
Yeah.
I think Tom is normal.
Yeah.
Whoa.
Massive rear pump.
Stop being so mean.
No, you look fine. Me?
Go on, Jay. Straight as a die.
Yeah, no, you're fine.
Yeah. Lovely.
Grand. All good.
Yeah, you'll have to. It's at about 18 minutes.
Okay, everyone wants to come back, please. Come back. Does anyone want to come back, please?
Yeah, often when he might when he definitely
It was just really, really fit, so he didn't turn the head. He was fit and he was mobile, particularly with it's the rotation that they often have. Get more rotation.
So that was good. One point that came up that from which is is, yeah, really, really important as well. Is also, when we talk about the psychological thing, that reassurance thing as well is also important. I know John does that, and I'm sure everyone else does that, but yeah, it's like with similar.
If you don't already know, I always get my patients to Google Usain Bolt because he's got scoliosis.
Oh yeah, there's the answer to the question at the end. There we go. Yeah. So yeah, Usain Bolt has one, and I think he's worked a hell of a lot on his hamstrings. I think looking at some of the videos. If you look at also online, there's many other sports personalities that have got scoliosis. I also, interestingly, because my lady from earlier works in the fashion industry, there's also a South American model with scoliosis.
She told you that.
So yeah, and
Yeah,
I think she's modelled for some of the top designers.
That well, doesn't it?
Okay, so this is just that video just showing, if you've got like a computer, it can make it easier. But again, look at this cob angle and how they might do it. Bit of an idea. So you can see at the top left there, that's kind of showing us our angle. So obviously, you can do it simply, or you can do it more complicated like this. So there we go. That's just showing the angles there. You've got the angles at the top there. Right. Right. So obviously we've got our Adams test that we can use quite simply, but now going to a bit more of the kind of the complex, I guess. This will be more stuff that will be done by the consultant rather than us, but just says a bit of an awareness, I guess, of it really. So X-rays wise, looking at standing, and standing AP, PA, and lateral views, supine views, with a side bender of all three curves. So a side bender, what that means is that you're take the X-ray, you then move the body as far as you can, basically. So it's basically to assess, is the scoliosis functional or structural? I.e., can you change that and make it more, which means it's more kind of functional, and can you correct that? Or can you not do that, and then it's more structural? So that's basically just, that's what that's telling you, basically. Generally, as a rule, looking into a couple of things, if it's over kind of 40 degrees, then they're looking at things a bit more kind of seriously in regards to the cob angle. You can use MRI or surface topography. So surface topography is I guess kind of what they use on kind of land, really. So it kind of gives you kind of that graph of where the curves and things are as well. Obviously, you've got with the MRI and the surface topography, or certainly with the MRI, you've got them lying down. So you haven't got the benefit of that weight-bearing element to it, which may reveal something that you wouldn't get lying down. Okay, so and if scoliosis is to be monitored, then X-rays and examinations will be repeated after a period of 6 to 9 months. That's roughly what they view them and then reassess them, have a look again. What's happening? So treatment for scoliosis. So this just shows an operation. So Harrington rod, and you're obviously coming in, but it kind of shows you how much metal work kind of goes in. So, as we come on to later, there's massive risks. So they really want to try and avoid this as much as possible. That's why they tend to go, particularly with children, more for the bracing, and the bracing tends to work quite well for people. So treatment-wise, so we can do observation, so just monitoring it, seeing what's happening. We could do exercise, we could do, then consultant-wise, we can do bracing, we could do surgery, but last resort really, as with all spinal surgery, because the risks are so massively high. So what's kind of a normal spinal curvature? So if you take a plumb line from C7, it should pass within a few millimeters of the superior corner of S1. Thoracic curve should have about between 10 to 40 degrees of kyphosis. Lumbar spine should be 4 to 6 degrees of lordosis. And the lumbar spine should have 30 degrees more lordosis generally than thoracic kyphosis. So, exercise for scoliosis. Yeah. Right, so let's go through these ones first. So, the first one is the Schroth exercises. These are the ones I went through earlier, and I'll show you in the video in a bit, which will demonstrate it and show it a lot better than I can kind of explain it. From what I found out and can see about it, it seems like it's all about getting the patient in various positions, using devices, so it could be a pole, it could be like a rolled towel, it could be one of those big foam arch things, to cause that correction of the spine, and then getting them to breathe in that position to ventilate these areas that are under-ventilated normally. But the video in a bit will show it a lot better than that. So we've got forward head correction exercises. So that's looking at head posture and shoulder posture and see how that's affected. Stretching exercises and strengthening exercises, muscles appropriately. So as a kind of a standard, as you would, as always, assess, see what you find, treat what you find. Self-correction and task-orientated exercises as well. That's the other ones there. And spinal stabilization exercises. So this is just some of the evidence behind some of the things we mentioned just then. So 2016, as you can see there, the carbon rotation angle significantly decreased using the Schroth exercises. However, there is no improvement in quality of life. So we can get kind of those structural changes, but not necessarily the changes in quality of life. There's high evidence that scoliosis-specific exercises should be the first step in idiopathic scoliosis to prevent and reduce progression of scoliosis and bracing. I don't need to brace as much. Correction of head posture combined with appropriate stretching and strengthening improved posture and function in those with idiopathic scoliosis. So with this one here, with the head posture correction exercises, the ones that they used, so they looked at shoulder posture, and just making sure that their posture and their shoulder was correct. They had a look at a stretch of the muscles at the back of the neck here. They had worked on the deep neck flexors as well. Those are the three. There was one other one they used, but those are the main three that they used. And they actually found some quite good changes from that. Reason behind some of these changes is that a lot of the reflexes for your spine and your spine position come from your head and your eyes. So if we can make these corrections, those reflexes come into place that then correct the spine or have some part in helping to align it properly. And supervised physiotherapy may be more effective than one-time treatment in decreasing pain, increasing function with those idiopathic scoliosis and lower back pain. So, as we know, with particularly, I suppose, more with our classes that are twice a week now rather than once a week, if they can be supervised and make sure it's the correct technique, then they can often get some better outcomes than if they do it themselves, because obviously technique does slip a little, can be effective at home. And scoliosis-specific self-correction task-oriented exercises improved cob angle. And then final one here, which is the Pilates method showed a reduction in degree of non-structural scoliosis, increased flexibility and decreased pain. caveat to that is that with this particular child here, they use quite high level exercises. It was a university population. They used quite high level exercises with a lot of kind of stretching involved with it, but also stabilizing the spine while they're doing it. So whether this particular trial can be applied to some of our older patients, probably not. Some of our younger patients probably could be applied. But again, would they, if we're talking children, would they have the concentration to do that? So we're kind of looking at a very specific, narrow band of people, really, to apply that to. So if we're stretching, what sort of things are we looking to stretch? So for a right concave primary curve, the main tight muscle groups are quadratus lumborum and the spinal paravertebral muscles on the right, the hip abductors on the left, the right hip adductors, the hamstrings, the hip flexors on the right, and the petroralis major, minor, and latissimus dorsi on the right. So you can kind of see that if you're looking to do these stretches and strengthening, it might be that you kind of assess it, give some things to begin with, give some stretches, maybe hamstrings or something like that, and then you might just need to kind of think about other things that you want to stretch and how that's going to have an effect and balance it. So quite a lot. Okay, so if we want to strengthen, what sort of things are we looking to strengthen? We're looking to strengthen the rotatory control muscles, so the multifidus on the opposite side, they've rotated to. So if they've got a right rib hump, they have weak left multifidus. The contralateral hip adductors and abductors on the ipsilateral side. Contralateral quadratus lumborum. Rhomboids, lower trapezius, ensuring control of lumbar lordosis, as always. So this is an interesting talk by Mr. Harding. Some of you may be familiar with him. He works down in Bristol, works for the Bristol Children's Hospital, also works in the adult side of things over at Southmead. He does a lot of the spinal stabilization surgeries. Often it can be that if something's gone wrong with like a different surgeon, quite often, sometimes they'll go to him to that correction. So he's very, very good. He did a talk, I think this is going back probably around about May this year. He did it on basically on spinal stabilization as well. This is just some of the key points. There's obviously lots of other points, but these are just some of the key points that I got out of it personally. So 1 in 20 have adolescent idiopathic scoliosis, and it's 10 times more common in female than male. They generally only operate for pain, breathing, cosmetics, and adult scoliosis. This is the quite interesting point here, that you can have up to a 90-degree curve. I'm not sure what evidence he used for this, but he said that there's evidence to suggest that you can have up to 90 degrees cob angle curve, with no detrimental effects to future life and activities of daily living. So that includes kind of childbearing and things like that. So it shows you can get to quite a big curve before actual detrimental effects on daily living and future life. Obviously, it doesn't necessarily mean that they can't have some intervention before that, but it just shows you how far you'd have to go before it would actually affect and stop you doing something. So X-ray could give a 10% discrepancy on cob angle. So it's not always accurate, and will depend on the position of the patient when taken. And again, that kind of comes back to Andrew's point about the consultant ordering them, because obviously they'll make sure that they're in the correct position and they've got the right views. So like Andrew said, you don't want to highly irradiate children, or if you're going to be doing it on children. Generally, if a scoliosis is small and gets to maturity, they'll generally be they'll be okay. If they have a larger scoliosis and get to maturity, it means the scoliosis will progress. Initially, more rapidly. So that kind of comes back to Joe's point now that if you've got a larger one, then obviously you need to be monitored more frequently. So usually you'll have a right thoracic curve and a left lumbar curve. If there's a left thoracic curve and a right lumbar curve, then it's a little bit more different to the norm, so slightly more concerning possibly. In children, bracing reduces the risk of a large curve. That the brace only for 11 hours a day. So, if he's prescribing bracing to children, this all the time, and that you only need to wear it up to about 11 hours a day. So yeah, yeah, exactly. So I think they're starting to bring that down to make it more.
Can those 11 hours be at night?
Yeah.
Like some of them at night time?
Yeah, yeah. Okay. And in children that operate for pain progression and cosmetics but high risk, the main surgical aim is to stop progression. So, as we all know, I'm sure that the risk in children are massively high. So you've got 1 in 5 chance of complications with spinal surgery, and that can be anything from interspinal bleeding, nerve damage, all the way up to death. So that's why they'll only consider operating if they failed non-operative management. So that's where we are. That's what we're involved with. Balanced expectations. So they know that this may help them, but equally it may not change anything. They might be exactly the same. They might even be worse further down the line. And if they're on the cusp of losing independence, I guess this is more with the adults really, but if they live alone and it's now affecting that they can't be independent on their own, that's when they might think about doing it. So this is kind of, the question's already come up and the answer's already come up. So someone, actually there's one before this. This is a bit of a controversial issue. Depending where you stand, and I'm sure lots of people would argue for this for hours. If someone has an apparent leg shortening due to scoliosis, do you give them a shoe raise? No. Okay, no is consensus. Okay, good. I'm glad we're all the same. Okay. And then, can a person with scoliosis be a professional athlete? And like was correctly responded that earlier. Yes, they can, because Usain Bolt has one.
Do you know how significant is this?
No, I think it does. Yeah, you can see it. Yeah, yeah. Basically, I think he just hammered a lot of stretches very frequently. I think all the sessions he was doing a lot of stretches. His coach was taking him right to the end. He was really getting into stretches. Yeah. So we've got a bit of a group task in a minute, but I'll just show you the video in just a second. So if I go through the group task first, then I'll show you the video, and then you can start the group task and I'll pop this back up. So if a patient presents you with a right rib hump on the left, with a rib hump on the left on Adam's test, pain is on the right hand lower back, you don't have any red flags, there's no neurology, could you create an exercise plan? So this is where it's all about sharing those ideas about what you do and what works for you, and say what outcome measure you might want to use. So this could be anything. It doesn't necessarily have to be something that we use. It could just be, I don't know, we have to do something in particular, for instance. So if the patient was 12 years old, then create an exercise plan and outcome measure for that. If the patient was 55 years old, again, create an exercise plan, create an outcome measure, and then I guess it's just about how might these be different from one to the other, and would they be different? Would you do it differently? So it's just sort of so I don't think we can get sound up, can we? But it kind of shows you anyway, I guess, really. So this is just them starting the group, really. Just looking at their breathing and making sure they're breathing equally to begin with at the moment. This video does show a little bit later about some of the exercises that they do with it. So this is them now. So they've got a band here around their chest. They're just working on that kind of breathing. they've got them sitting on a ball, they've got them looking into a mirror, trying to self-correct as well. This lady here is just trying to get them to breathe into certain areas along there to try and get them to work that. Again, doing the same, but this time using a stick to try and keep them upright there. So it's a lot of kind of self-feedback, self-correction within this as well. This just shows you a couple of things there. I mean, obviously this course is not like some of the other courses. You have to go on specialist training for it, but this is just more of an idea of the sort of things that they do. This is mainly used in Germany, but just an example of some things that they do in Germany to help with that as well. So again, it's just trying to get them to work in certain areas there as well. So, we leave it there for that one there. Different. And I guess this just shows it again, this time we're using a roll, and we're trying to expand it over that. We're trying to get the expansion there. So it just shows you different piece of equipment and how they're using that, really. To make that correction. Okay, so. So if I put that group task back up again, and then maybe if you just go off into little groups you want to, and just, try and create some exercises, share ideas about what works for you and what